Blazek. I'm the Nurse Program Manager for the clinical programs of the Office of Children and Youth with Specific Healthcare Needs. I would like to welcome you today to our discussion, Advancing Care for Children with Sickle Cell Disease, a Provider's Guide. We have a few slides for you. First off, disclosures. None of the planners or faculty for this activity have any relevant financial relationships to disclose. Also, if you're interested in getting a nurse continuing education unit for this, it's been provided by the Maryland Nurses Association, which is an accredited approver by the American Nurses Credentialing Center Commission on Accreditation. And also, in order to receive that contact hour, you'll have to attend the entire session, complete and submit the pre-test, which is in the chat, do the survey and post-test. I thought I was going to email it to you, but it will be in the chat as well. And if you need it to be emailed to you, please just let me know. You'll have 48 hours to complete that and send it back to us if you don't do it at the end of the session. And then when I get it all back, you should have your certificates by September the 17th. That being said, I would now like to welcome Dr. Jason Fixler. He's a graduate of the University of Illinois Chicago Medical School and did his pediatric residency at University of Illinois at Chicago. He did his pediatric heme-onc fellowship at Children's Hospital of Oakland with Elliot Vicinski, one of the leaders in sickle cell disease. He's been treating sickle cell disease in Baltimore since 2002 at Sinai. He's a member of the statewide steering committee on sickle cell disease, and he's participated in many nationwide sickle cell trials such as STOP 2, Baby Hug, and SIT. Dr. Fixler, I'll turn it over to you.
Well, thank you. Thank you for having me. You guys on the other line, I'm very passionate about this disease, so you may have to lower the volume. I may start screaming. Just be careful. Let me make sure I can share everything. Let me know if this works. Hopefully it does. I tried this yesterday and it did work. Are we good?
We're good.
Okay, yay. So this is, I've given obviously this talk many times in different places. I'm trying to gear this more on the outpatient side. Many of the times I've done this, it's more on the inpatient side. So hopefully I won't bog you down with a bunch of details that you don't need to know. And so here are the objectives. Hopefully we will get these through all of these. So this is kind of a tongue-in-cheek view of what people see as sickle cell disease. You get your newborn screen, it suddenly says they have hemoglobin SS, let's say, and then it's like, let's get them to the hematologist ASAP, or at least hopefully that's the way things are. And then kind of we take over a bit, although we need it to be more of a cohesive thing, and hopefully that's the way it's been going. At 2 years of age, we were like, oh, because they're constantly getting admitted because they have fever, and I'll go over that a little bit more. And at 2, we kind of decreased that. 5, there's the penicillin issues, and we can talk more about that. And then kind of going on from there, just kind of a tongue-in-cheek thing. The history, I don't want to bog you down in too much detail. One of the things to really look at is this has been going on for a long time. Although we've made some advancements, a lot of it has happened in the latter part of this, after 2010 and beyond, which is a shame. This is a disease that affects a lot of people, and the advancements haven't quite been there. Dr. Herrick described the first patient. It was actually, I think, a medical student. We went on and didn't do a whole lot in the advancement of sickle cell disease. Gave, some pain medicines here and there, but the addition of penicillin really saved lives, and I'll go over the study on that briefly. We then later on found finally a medicine that can help control things a little bit better with hydroxyurea, and then started looking at more of the brain as a major issue with sickle cell disease. And those are kind of the studies, the STOP trial, the STOP2 trials, SWITCH, TWITCH, and SIT, all revolve around the brain. Transplant has been going on for quite a while, since the 80s, when there was a young child at St. Jude that had, I believe, AML and needed to be transplanted. Got a transplant from her sibling, and they, lo and behold, cured her not only of the AML but of the sickle cell disease. And then we've gone on to go on and do more and more transplants, and doing them in different ways. And I can talk a little bit more at the end if we have time about that. So why do we care? Well, it's a very common disease. Around 8% of people are affected by the sickle cell trait, which is an important thing. And as a side note, you're going to get your newborn screen showing that they're either AA, normal hemoglobin, or they're sickle cell disease or sickle cell trait. And a lot of times when you get back to sickle cell trait, it's like, phew, they don't have sickle cell disease, so we can forget this. And that's a big issue. And the parents sometimes forget. So I would, bring this stuff up if they have trait, at their 5-year-old appointment, at their 12-year, as they get older, reminding the child that they have sickle cell trait. Because if they lose track of that, then when they are thinking about having children, they're not going to be educated in those decisions. I'm not saying they necessarily, would abandon their partner if they had trait, but they may make different decisions as far as having children, or they may not, but they should at least know what's out there. In areas like Nigeria, it's almost forbidden to have two people knowingly with sickle cell trait marry each other. So again, don't lose track of this. Remind the parents, and then remind the child as they're older in the teenage years. And then about 1,000 children are born with sickle cell disease every year. So obviously a very important disease to know about. And you're likely, especially in the Baltimore area, have children definitely with the trait, and probably many children with the disease as well. So it occurs, there are two genes that are part of the hemoglobin. There's the alpha chain and the beta chain, and you have two alphas and two betas. The beta chain is where the sickle cell issues happen. And if you have two abnormal mutations in either the sickle gene, you can have a thalassemia, as I'll talk about, or C, and then there's some minor ones like Lepore. And if you can either be a homozygous for sickle cell disease or a compound heterozygote, and have two different variations, can result in the sickle cell disease. The large picture here, I don't know if my pointer is showing, but it's a normal cell shaped like a bagel, shaped like a donut, sort of. There's not really a hole in the middle, but it's concave on both sides. And then to the right of that is the sickling cell. In normal environments, patients with sickle cell disease will have these go back and forth, but sometimes they can be irreversibly sickled, and that's an issue as well. And we'll go into the many issues with this problem of sickling. So again, as I said before, you can either be a homozygous in this mutation, and that's the sickle cell hemoglobin SS, the most common form of sickle cell disease, and typically the most serious. If you inherit one sickle gene mutation from your mom, let's say, and a beta 0 thalassemia mutation, meaning that they're not making any beta chains, you will have a disease called sickle beta thalassemia 0, sickle beta 0, which behaves exactly the same as SS. And so they are in the same trials. again, you don't do anything different between the two, but the inheritance pattern is very different. And you can run into the issue where one parent is like, I have trait, and the other parent is like, I have nothing. So how did we have a child with sickle cell disease? And the truth of the matter is, one had the beta 0 mutation, and that combined, which is all the more reason why you have to educate people if they have the trait that they need to investigate their partner, not only for sickle cell trait, but for other traits as well, beta thalassemia or C disease, or again, Lepore, and some other ones. I'm not going to go into the very minor ones like Lepore and SOR Arab. Those are very uncommon, but these are the most common, with SS being the most common and then S beta 0 being the same. SC is one parent has S and one has C. These tend to be less severe, although I've had patients with a lot of severity, a lot of issues with SC disease, and I've had patients with SS that have had less severe disease than SC. But on the whole, SC patients typically do much better, have milder symptoms. Some even in like Africa get unrecognized as having sickle cell disease because they have no issues. They may have occasionally some pain here and there. Some of the issues may be not uncovered. You still can have issues with retinopathy, as I'll go in future. You still can have issues with bone issues, and they may not have pain, but they can have some of the other issues. But again, these patients can be very severe, occasionally needing transplant. But again, they don't have all of the issues of SS, but kind of have many of the pain issues. And then finally, S beta plus thalassemia, which means they have a sickle gene, and then one of the other beta gene will make some normal hemoglobin A, and these tend to be the least severe. Most patients are asymptomatic or have symptoms only maybe once a year, once every couple years. Again, I've had some patients that have had fairly severe disease, but on the whole, there's not many problems with these patients. And these are some of the patients that we lose track of because the parents are like, well, they don't have any issues. We're not going to see the hematologist. So again, this is a newborn screen thing. So here's pictures of an electrophoresis where you're seeing under hemoglobin AA. This is the control. It's not really mapped very well, but this is A under the lower line. And so this patient only has A. The next patient with AS has a line at the A and a line at the S. Then you can see the SS patient only has S because that's all they're making. SC will have a line at S and a line at C. And then S beta plus will have the line at, it's again, not very bright, but there is a line at A, which is not as bright as the line at S, meaning the S is greater than A, and that signifies someone with S beta plus. This is for adults. Underneath, you'll have another, obviously, they're making fetal hemoglobin. So someone with AA or normal hemoglobin will come back as FA. Someone with trait will come back as FAS. The A hemoglobin is going to be in greater proportion than the S. And that's important because patients with S beta plus will come back as FSA. And so that's how you can recognize, or how we recognize, the difference between disease and trait is that the S is greater than the A. And again, then they go on to become SA, and then FSC to SC, and FS to SS in both the S beta 0 and SS disease. And so that's what we get back, or you get back, is that this patient has FS or FAS, and that's how you can tell whether, now there will be a description on the bottom, but that's how you can tell whether they have trait or S beta plus or SS disease. So once we get that, then obviously they need to be sent to the hematologist. And again, later on, we'll talk more about that. So what happens? These cells, the hemoglobin S molecules will form a polymer. They'll connect to each other and form these kind of sticks. Where they polymerize and form these sticks, they then cause the cells to malform, into this oblong sickle shape. And so what does that is low oxygen. And so even in patients with trait, if you get low enough oxygen, you will get sickling. So when we look under the microscope, we'll see sickling. A high hemoglobin S concentration. Obviously, if you have SS, they will be the highest concentration. Whereas if you have sickle beta plus, you'll have some A in there to inhibit it. And therefore, they have fewer issues. And in the newborn period, you have a lot of F. So you typically don't see issues in the newborn period as far as pain goes. Again, infection is a whole other issue. You can see that quite early. But pain you typically don't see in the first year of life. And in fact, if you see it in the first year of life, that's a bad, it's an issue. These are the patients that are typically with the most pain crisis or have the most issues. And so the higher the hemoglobin S concentration, the more likely they are to polymerize. And then you can use ways of increasing hemoglobin F or other things to decrease the polymerization. Low pH, elevated temperature, and that's within the cells. And so that, sometimes with fever, you can get more pain crisis. Intracellular dehydration, again, obviously within the cell, and that's something that we'll pay attention to later on. But if they become dehydrated, you get more sickling. And then the higher you get the hemoglobin A and F, the less they're going to sickle. And again, here's kind of a cartoon showing, the normal cells are going to be able to get through this opening without a problem, but the sickle cells get trapped. They then cause decreased oxygen to the affected area. This is the microvasculature. These aren't the major vessels. These are the feeding vessels to the major vessels, the feeding vessels to the tissue. So if the tissue or these other vessels have decreased oxygen, you're going to get swelling, and then with that, you can get the pain. Or other issues like decreased blood flow to major arteries and whatnot. Pain crisis starts in the newborn period. Again, typically when they're older than a year, but you'll get swelling of the hands and feet with or without pain, typically with pain. Really difficult to understand because the child typically can't talk at that age, so you have to assume that they're in pain, especially if they're crying, and we treat it as such. As the child gets older, the pain becomes more central. So starting in the hands and the feet, later on going to the arms and legs, and teenage years, it's more centrally shoulders, back, chest, and then in adults, it's typically the chest and the back where these pain crises are occurring. So what do we use for pain crisis? Well, we'll use drugs such as morphine or NSAIDs, and we'll talk more about that. We talk about hydrating. So this is a big issue. Yes, dehydration can lead to increased sickling. And that's why when they're participating in sports and other things, you're saying, make sure you hydrate. It's particularly important in sickle cell patients because they cannot concentrate their urine very well, and so they're more prone to dehydration. So yes, dehydration within the cells will cause increased sickling, but giving them more hydration does not help during pain crisis. People love giving lots of IV fluids to wash the cells away like the itsy bitsy spider. This is not the case. What happens is they get loaded with fluids. The fluid does not go intracellularly because the cells are fine, goes extravascular and into the chest, and other reasons, and then you can get acute chest syndrome. So one of the modalities is not to flood the patient with fluids. If they're dehydrated, treat the dehydration, but hyperhydration does not help. That being said, also, if they're hypoxic, that's going to cause more sickling. That's why you hear about patients or kids with trait or adults with trait having issues at high altitudes. You don't see a lot of rock climbing and whatnot. When I was in California, actually, where I trained, Tahoe was nearby. I did get one phone call from them, but rarely do you see kids with sickle cell disease doing these kind of sports, skiing or high altitudes. But low oxygen can cause a problem. By all means, we should keep them normal oxygen. But if they're coming in with normal oxygen, 98%, 99% in pain, adding oxygen does nothing. You're just over treating it. Now, one can say, well, why not? It's not causing any harm. Well, my Ellie Bashinsky used to say, well, you could suppress their erythropoiesis, leading to more issues. I don't know if I totally buy that. What I get worried about is one of the vitals that we like to use is pulse ox. And we like to see if that's going down, that's an issue. And so if you're giving them supplemental oxygen, it's going to be a while before you see any decrease. And it's probably when they're crashing. So that can be a subtle sign that there's an issue and you lose that ability. So we like not to give high amounts of oxygen for no reason. What do we do? Again, this is not something that you guys have to concentrate, so I'll go over this very quickly. But typically we're giving narcotics. Stay away from most long-acting ones. We're typically using short-acting ones, especially as an outpatient. You're using oral. And then if they're admitted or in the ER, sometimes we'll use IV pain medicines, narcotics, typically morphine, but you can use other ones such as Dilaudid. And then if they get inpatient, we typically will go to a PCA, which will allow us, people get nervous because they're going to use too much of the morphine, but there's studies showing that if you use a PCA, you actually help with pain and decrease the amount of morphine needed. We tend to forget about Tylenol or acetaminophen. That's helpful. A diphenhydramine can help with some of the itching. There becomes an issue with IV diphenhydramine. It can give you a little bit of a high, and it can cause altered mental sensorium and issues with that. A lot of places will try to avoid the IV form. Because these patients typically will have histamine relief, they're on a naloxone drip, small amounts. Again, oxygen only give if they have low oxygen fluids. You give sparingly, especially if they're able to drink on their own. Blood is typically not used for pain crisis, although it can help in the long run. But the ASH and other groups do not recommend giving blood for the treatment of pain. We are now looking at ketamine. This is being increasingly used in the inpatient setting to try to spare for narcotics. And then there's some other ones. Amitriptyline, I use quite a bit. Helps with sleep cycles. Obviously, there's the antidepressive effect, and also can decrease the amount of narcotics you need. We also use gabapentin. And some places have used epidural with variable success. Again, that's more inpatient stuff. Well, what's going on in the patient? Well, they all have decreased splenic function, and this is at birth. And this is what causes some of the issues with sickle cell disease. So they're functionally asplenic, and therefore they're more prone to encapsulated organisms. And prior to the penicillin trial, the first signs and symptoms of someone with sickle cell disease prior to doing universal testing in the newborn period was they would come in septic. And then you would say, whoa, this is not normal. And they'd have pneumococcal infection, and then you test for sickle cell, and there you go. Thankfully, that's not the case anymore. Someone have pain crisis, but you obviously don't want someone coming in septic. This is the case in a lot of areas in Africa where you'll hear about fetal demise, and many of these patients probably had sickle cell disease and just weren't started, was unrecognized and not started on penicillin prophylaxis or aggressively treated. So the autoinfarction causes increased risk of infection, as I said, capsulated organisms, and mainly Streptococcus pneumoniae. Now, Salmonella, Neisseria, and Haemophilus, yes, but Strep pneumonia is most common. Thankfully, with vaccinations, these have decreased dramatically, and we don't see them as much, and with improvements in vaccination. So the vaccinations are key to keeping these patients safe. These vaccinations happen in your office typically. Can we give them in ours? Yes, but it's better to have them in all in one source. And so we depend on you guys to make sure that these kids are vaccinated. And later in the talk, it goes through, what they need. Here, pneumococcal and meningococcal vaccines, the standard stuff initially, but also what we used to do, the PCV, the pneumovax, the PCV 23, or now the PCV 20. So these are additional ones that they need, and then making sure that they have meningococcal vaccines, which are becoming more and more common in the newborn period anyway. But these are very important to give the children. We start them as soon as they're recognized. You guys can start them on penicillin prophylaxis. They say to start at a month or 2 months or 3 months. I mean, there's no downside to starting immediately. Have I seen a 2-week-old come in with pneumococcal infection? No. But that doesn't mean they can't. So I would start, as soon as you find out before your referral, start them on penicillin prophylaxis, which is 125 milligrams twice a day for the first 3 years, and then they go up at age 3 to 250 milligrams twice a day. Typically, if it's, you're using liquid at this age, although you don't have to, if you're using liquid, keep in mind that the liquid formulation only is stable for 2 weeks. So you give them 2-week supplies that they have to renew every 2 weeks. Occasionally, pharmacies will give them additional undiluted penicillin and then the diluent, and then the parents can do this at home so they don't have to come in quite as often. But you can't give them multiple doses that have been the diluent has been added to, because those, again, once the diluent is added, it's only good for 2 weeks. Studies have shown we can stop this at 5 years. For sure in patients with SC and S beta plus, no issue. The big study, and again, the penicillin prophylaxis came about is a study that we did where we had half the patients on penicillin, half the patients not. That trial was ended early because of increased morbidity and mortality on the side that did not get penicillin. And so everyone got penicillin. Everyone got penicillin indefinitely until a later study where we stopped it at 5 years of age. Patients that were stopped compared to those that didn't, there was no major difference that were statistically different, but there was one death on the non-penicillin arm. Also keep in mind that the pneumococcal, during the study, pneumococcus was not very common in the community. Now, again, it is less common now as well, so take that as you may, but that was some of the critiques was, well, why are we stopping at 5 years? There's not much difference, although they have been vaccinated, and now that we have the conjugated ones, they get vaccinated much earlier. But what is the big difference? Because at 5 years, they still have no spleen. And then also, when we take out the spleen, we will then continue them indefinitely on penicillin. So what is the big difference? Well, probably all these vaccinations and herd immunity has been helpful. And so you can stop penicillin at 5 years. Again, the only kids that I've seen have pneumococcal infection are those that were greater than 5 years. Does that mean putting them on prophylaxis would have helped? I don't know. Now, if you've had pneumococcal infection or your spleen is out, we continue it. But most people can stop at 5 years. I would say probably 90% of the hematologists are stopping penicillin at 5 years. The vaccines that I talked about, and then if they have fever, they need to be seen in an inpatient setting. Do not give amoxicillin for otitis media if they have a fever, because that fever may or may not be related to the otitis media. The otitis media may be off, and so they need to have blood cultures to make sure that this is not pneumococcus. If they're under 2 years of age, they get admitted. If they're above 2 years, we give ceftriaxone and then give a couple days of antibiotics. But we need to get a blood culture to make sure that they do not have pneumococcal infection. And if you're just giving amoxicillin, that may be treating them temporarily, and it's not a good way to go. Admission, some institutions are going down to 1 year of age and training out patients above 1 year. We're still doing 2, although that's being looked at. But all patients under 1 for sure get admitted for IV antibiotics. Yeah, so the infection is a really important issue. And again, making sure that they're vaccinated is super important. Another common issue is acute chest syndrome, as defined as a new infiltrate on chest x-ray. And then you have to have that, and then fever, chest pain, respiratory distress, and increased oxygen requirement. This is the #1 cause of death in adults, and you really have to be careful with it. And as this is an x-ray of someone that came in with mild chest pain, and maybe there's a little bit of haziness here. And just 24 hours later, you can see complete whiteout. So again, you got to be very aggressive. Again, a little bit of haziness here, but looks pretty good. But you got to be very aggressive with the treatment of this. Otherwise, you can have respiratory failure. And then again, is the leading cause of death in adults. What do we do? Again, I don't want to bog you down with the inpatient management. If it's acute chest syndrome, we'll typically do a transfusion to decrease their S. That can be just a simple transfusion, giving them blood, seeing if that changes it, or an exchange transfusion where you're taking blood off and giving blood back in. That's a more aggressive treatment, sometimes needed if they're not doing very well, but also if they have too high of a hemoglobin and you can't give them a simple transfusion. The exchange transfusion also will drive the hemoglobin S much more quickly. And so again, if they're not doing very well, that's the way to go. The issues are you have to take blood off. If you're using a machine, they usually have to have a central line. So sometimes if you can get away with simple, that's probably the way to go. If they're hypoxic, giving them oxygen for sure. I mean, we're typically at this point giving them oxygen because that's one of the cardinal signs. We're giving them antibiotics. I put cefuroxime. Typically, they're getting ceftriaxone. We also give them a macrolide. And the reason is both for community-acquired pneumonia as well as chlamydia pneumonia. In the adults, there was a bronchoscopy trial that bronch these patients, and the most common organism was chlamydia pneumonia. So we give both for atypicals as well as for chlamydia, and give both these antibiotics. Pain management is a key because they'll commonly have chest pain, so they may be on a PCA, but getting them to take deep breaths is critical. And there was one study showing that they had decreased acute chest syndrome for those patients that did more intensive spirometry. So again, keeping that air movement going is very important. Monitoring hemoglobin, again, it can drop. We're trying to get the %S down. CPAP, we're using more and more often now. Some of the patients will try to get away with high flow, but it's to keep the alveoli open, and we have had some good luck with that. And there are some trials using CPAP showing better results than just using conventional oxygen. And then there are some studies that have used the nitric oxide and arginine with some degree of success. The transfusions, again, I'm not going to bog you down. All transfusions are leukophore filtered to decrease infection rates. We use phenotypically matched blood, and this is important to know, is we don't try not to use just blood straight off the shelf, because many African Americans have minor antigen that are positive or negative that are not typical for Caucasians, and about 75 to 85% of the blood at the blood bank from Caucasians. So they're going to be mismatched. It's okay on the first transfusion, but many of these patients will then develop antibodies, and then it becomes harder and harder to give blood. So we will phenotypically match them and then give blood that matches a couple of the minor groups, C, E, and Cal, and that is a decrease the amount of antibody formation by about 95%. So this is the issue when they're treated at non-sickle cell knowledgeable places. they will just get blood right off the shelf, and then they'll develop these antibodies. So again, very important to get these matched, partially matched units. We use sickle cell negative blood. That's because later on when we do the electrophoresis, it can cause some issues in getting accurate results. And then over long periods of time, the simple versus exchange. In the acute management, it's not a big deal, but the exchange transfusions over long term will lead to decreased iron overload, but more donor exposures because they're typically getting from 4, 5, 6 donors. Whereas simple, you have less donor exposure, but you have more issues with iron overload. And the next common issue that you may see is orthopedic issues. Osteomyelitis, that's what gets quizzed on. Rarely see it. Most likely it's staph, but if you have a patient with salmonella osteomyelitis, think sickle cell disease, think asplenia because it's very uncommon in patients that have normal splenic function. The more common thing we see and that you may see is avascular necrosis of the femoral head. You get a blunting of the femoral head. The way you can do it and the way I check in my office is doing internal and external rotation at the hip. The first signs are typically decreased range of motion without pain, but later on with pain. And then people will get x-rays, but typically if you see something on MRI, you can miss it on x-ray and it's positive on MRI. So I go straight to MRI. And the reason you do that is because early intervention is the key. So here you have an area with a flattened femoral head and avascular necrosis. And what they do, the orthopedic surgeons, if you catch it early without collapse of the femoral head, they can drill into these areas of necrosis and allow for revascularization of that area. And that has been shown to work very well. Later on, you need total hip replacement, or sometimes they'll use hip extraction. Some will resurface the bones, but again, early intervention is the best because you can get away with just a simple outpatient procedure of drilling the femoral head. In pediatrics, we don't worry too much about the cardiovascular side of things. That's typically happening in the adults. But we have to pay attention. And the big reason is for iron overload. Those patients are getting chronically transfused either for neurologic events or for pulmonary events will have iron overload and can lead to cardiomyopathy, but typically more on the adult side. Priapism happens a lot more than we know. So it's important for you guys. We asked also first defining it and telling them that it's a painful erection and introducing it at an early age because if it continues, you can have decreased sexual function. The incidence I see there is like about 25%, so very common. The sickle cells get caught and causes constant erection, which is painful. The treatment now we used to use transfusion solely with some hydration. Now it's the phenylephrine direct injection into the penis with aspiration and then injection of the phenylephrine, and that's been shown to work very well. It's a temporary solution, which can be useful for most patients, but many patients will have recurrent priapism, and that's where it becomes an issue. We'll use Sudafed sometimes for that. I use alkalinization when they get admitted, but for the chronic patients, Viagra has been shown to maybe be useful. The urologist will teach them self-injection. In really bad cases, they can do shunts and fenestration. The issue is that if it's a permanent shunt, that will cause impotence. The fenestration, where they put holes between the spongiosum, cavernosum, that will cause temporary flow, and then you should get scarring, so you shouldn't cause impotence. But these are major issues, and you want to catch it early and treat it aggressively because it can lead to impotence. And it's a tough subject to talk about. So again, early introduction to the subject is good, so it doesn't become kind of this thing that no one talks about. Many patients, and again, on your history, you should ask about this. Nocturnal enuresis. Patients with sickle cell disease have decreased ability to concentrate their urine. and therefore need to go to the bathroom quite a bit. During the day, it's not a big deal. They just have frequent bathroom breaks, and sometimes they have to write notes on that. But at night, they typically should wake up once a night. And the young kids do not. Some of them are very aggressive sleepers or sound sleepers, and they have nighttime bedwetting. This is not something that can be, that they need to learn how to hold it more, yada, yada, yada. This is something that they need to just wake up at night. What I typically tell them is initially set your alarm once or twice. The parents probably have to help, and you wake them up, and eventually they'll wake up on their own, but they just can't go the night. And this is an issue because teenagers have, sleepovers, you have camp. Occasionally I'll use DDAVP for like a short-term solution, but again, that's not going to cure the overall issue, which is they need to wake up at night and go to the bathroom. These patients also need to see an ophthalmologist yearly. Usually I send them to the ophthalmologist once they're able to sit in the chair. It's relatively uncommon for pediatric patients to develop the retinopathy, but we do see it, and if you catch it early, it's due to, similar to diabetes, you have proliferation of the vessels near the retina that can cause retinal damage. And then if you use, similar to a retinopathy of prematurity, laser therapy to decrease the neovascularization, this is treated. Later on, you could have retinal detachment and then blindness. So you really want to have them see them yearly and then treat this aggressively if needed. A relatively uncommon one is retinal artery occlusion, which can lead to blindness as well. Hyphema is something for you guys to keep in mind. Patients with hyphema that have hemoglobin trait, that's a medical emergency. That's really the only thing you have to worry about with trait. Yes, there are these issues with sickling in extreme situations like in NCAA practices. I would argue if the practices are causing sickling, they're probably overdoing it, and the other people are having issues as well. So rather than saying that the sickle cell trait patients shouldn't participate in practice, they probably need to change the practice. That being said, a hyphema, because there's low oxygen tension in the eye, they need to go to the ER and have it immediately evacuated because you will have sickling in there, which can lead to glaucoma and increased pressures within the eye. So again, very important. So what do we do as far as therapy? We're trying to inhibit sickling. So you can do transfusions that decreases the amount of sickle cells within, but also increasing the volume of the cell. That was a thing we talked about, making sure they're euvolemic. We have tried hyponatremia. The issue with that is, yes, they get decreased sickling, but it leads to stroke or leads to seizures. A big thing is increasing hemoglobin F. We know when babies, they have decreased pain crisis. There's also a group of people that have increased fetal hemoglobin, persistent fetal hemoglobin, and they actually have no sickle-related issues. And so we use this increased fetal hemoglobin to help with treating this disease and preventing it. And this is just a quick graph showing the survival, and the higher the fetal hemoglobin, the better. The hydroxyurea will increase fetal hemoglobin, thus leading to decreased sickling. And so we did the baby hug study showing that it is safe for babies as low as 1 year of age. There was many other studies showing that it decreases pain crisis and decreases acute chest syndrome. So all patients with severe disease typically go on this. Also, in many institutions, they put everyone on this because in the baby hug study, it showed decreased amount of sickling, decreased amount of pain, and really not many side effects. So people argue if you don't have very many side effects, you might as well utilize it. Other people look at it as it did not show it prevented end-stage disease, such as preventing renal disease, preventing stroke, and so why give it if it's not going to be helpful to those people? So mixed bag. We typically give it to everyone that wants it, and then everyone that is having frequent pain crisis or chest syndrome. And again, these are the trials that showed that they were safe. There was a medicine, I'll be really quick about it, called Voxelotor. I don't know if you heard about it. Came on the market, caused decreased sickling, and was thought to increase the hemoglobin, and was thought to be this great drug. It really didn't change the episodes of pain crisis, so I was a little bit off with it. And then later trials, during the trials, showed increased death in some areas, and so it was pulled from the market rather abruptly. And then the other drug, crizanlizumab, which is a P-selectin inhibitor, allows also called the Dactyl, allows the cells to kind of not stick as much. And what initial trials showed that it decreased pain crisis, decreased hospital days. It seemed pretty good. It's an IV that you had to give monthly. We actually were seeing a lot of people with chest pain, and it wasn't decreasing their pain crisis. So we were suspicious, and then later on, a European study showed that it did not. It was the same as placebo. So not many people are utilizing this as well. Some people are trying it for priapism. So again, the two drugs that we were so happy that came out recently proved to be all that not helpful. The third drug, glutamine, has some data that supports it, but people don't like the gritty taste. It's fairly expensive, and I have yet to get people to take it because it just tastes terrible. Really quick on the neurology stuff, and which is very important. There's risks of stroke, and we determined through studies, the STOP trial, that if you have abnormal transcranial Doppler greater than 200 centimeters per second, that you are at about a 10% risk of stroke a year. And so we realized that, and so then we placed patients on transfusions, and some patients without transfusions. And the patients with transfusions had almost no, there was one patient with a stroke, whereas the patients without transfusions had still the 10% chance. So our current recommendation is if you have an abnormal TCD, and you have to get these yearly. Now we'll get these, but you can remind your patients that they need it. If it's greater than 200 centimeters per second, they should go on a chronic transfusion program. Now the question is, for how long do they go on this transfusion? In STOP 2, we stopped it abruptly if their TCD velocities normalized and showed that they had reversion of abnormal TCDs and had stroke. So we said, well, we can't stop abruptly. That does not help. But with the Twitch trial, we then said, okay, as opposed to just stopping, let's give them hydroxyurea. And that showed that was superior to stopping it, probably not as good as continuing transfusions, but led to decreased iron overload and other issues. So that is an option for some patients. And then finally, the SID trial looked at silent infarcts. And again, these little areas on the right side, there's like these little bright areas, which we used to call unidentified bright objects. And they're seen in older patients, especially patients with diabetes, but are not seen in kids. And we saw this as we saw these in sickle cell patients, and we're like, is this happening with their siblings? And it's not. And it's happening in about 30 to 40% of kids with sickle cell disease. So why do we care? Well, they have the patients with the silent infarcts, when compared to sickle cell patients without silent infarcts, and their siblings have a lot of issues as shown here. Not obvious neurologic issues, but issues with school and memory and language. And so in the SID trial, we then transfused them, half the patients not. And it did decrease the incidence of repeated silent infarcts, a little bit on stroke, and a little improved school performance, which was great. But you had to treat about 13 patients to get one patient that had a good result. So the question is, if they have silent infarcts, what do you do with that? What we do is, I'm going through this quickly. These are the aims of it, the SID trial. But what we do is check it. We will either do neuropsych testing to look for things, or check at 6 years of age. Many places will do MRIs at 6, see if they have a silent infarct, and then if they do, offer them transfusion or not, and go through the risks and benefits. Again, the benefits are you're having reduced rates of stroke, pain, acute chest syndrome, but you have to treat a lot of patients. So some of the patients are getting some of the burden without any of the benefits, which are the blood transfusions. You have to come in quite a bit, and then the excess of iron stores. And then finally, what are we doing next? Well, transplantation, as I said, we've been doing for many years, but we're getting better and better. And now we're doing many more what's called haploidentical transplants, So even if you don't have a matched sibling, you can go to a parent or an unmatched sibling that is a partial match, a 3 out of 6, and use that for transplantation. And that is having increased success. So now more and more patients can get transplanted. There are also, you probably read the gene modification where you take the patient's bone marrow out and then you modify their beta hemoglobin so that they make fetal hemoglobin to the point where they don't sickle. And this has been a curative process and has been shown in adults to work quite well with no risk of graft versus host disease as you see in transplantation. You still need to give some chemotherapy, and the biggest issue is there's not very many places that do it. I think it's about 13 now, so there's limited ability for patients to get this, and it costs about $2 to $3 million, which is kind of crazy. So I think once we get rolling with this, more and more patients will get this gene modification. So again, what are you really concerned about is the health maintenance, making sure that they get the conjugated pneumococcal vaccine, the meningococcal vaccine. I have in here multivitamins. That's plus or minus, not really a big deal. We're going to see them, hopefully by 2 to 3 months of age to make them aware that they have sickle cell disease. They need to continue the penicillin prophylaxis. And if they have fever, do not give Motrin, do not give Tylenol, do not give any antipyretics. You call the hematologist, do not pass go, do not collect $200. They need to go to the emergency room, get IV, and treat it. And that's up until about 2 years of age. Again, continue with all of their vaccinations. We will start their transcranial Doppler at 2 years, and then they get it yearly until they're around adult age. Influenza vaccine is very important. I've seen a lot of patients, depending on the influenza, when they get it, it leads to acute chest syndrome. The H1N1 variant caused a lot of acute chest syndrome, so that's important. And then we get yearly, we'll get yearly labs as well. Penicillin prophylaxis will stop typically at 5 years of age. We'll do the ophthalmology exams, probably get MRI of the brain at around 6. Some places recommend echocardiograms to look for pulmonary hypertension. We do it on most of the patients. And then yearly ophthalmology exams starting, unlikely at age 5 that they're going to have issues, but once they're able to sit still, that's probably a good idea. COVID vaccine, again, I recommend it. How many do you need? That I don't know. But COVID did lead to acute chest syndrome and a lot of admissions and a lot of pain crisis. So if we can prevent it, that's great. Finally, the state releases, and I think they're going to send this out, kind of a list of what these patients need, both from our end and in your end. And the big thing is the immunizations. We depend on you guys to give these immunizations, and we're kind of assuming you're giving it, although we will check on it. There have been some issues getting some of the meningococcal vaccines, and we've arranged either for them to come here or been able to get the vaccines to you guys. But that's what we're really dependent on. And also, what's going on, as far as learning, how they're having issues, because that can be a sign of silent infarcts. So making sure that they're getting to school, putting in the CHIP program, all of these things, we depend on you guys. And if you have issues that you're seeing, let us know. So this should be going out to you guys. And that is it. Have a little bit of time for questioning, and here we go. I don't know if I bored everyone or not.
Feel free to put any questions in the chat. If you're not able to unmute yourself and you just want to raise your hand, you can do that as well, and we'll get you unmuted.
Maybe I covered everything and no one's got questions.
We'll also be sharing a recording of today's webinar with those of you that are registered. So please feel free to share that as well if you know anyone that wasn't able to make it.
And I have put links to the post-test in the chat for anybody who is going to apply for continuing education credits, as well as an evaluation link. We'd really appreciate everybody's feedback if you wouldn't mind filling those out.
Okay. Well, hopefully you got something out of this.
There was a question.
Yeah, not really. So the folic acid is a big thing. I didn't mention it. In Africa, they'll always be on folic acid. We looked at folic acid in the United States, and most of the grains and breads and cereals have folic acid, and patients were not deficient with folic acid. The theory is that increased cell turnover needs more folic acid, and so they should be on it. Now, is there a downside? No. And females should be on it anyway when they get older. But there is no real diet that we tell them. Some patients have iron overload, but we typically don't tell them to do anything with decreasing their iron consumption. So not really anything there. I saw something about nocturnal enuresis. So nocturnal enuresis stops when the patients are able to wake up on their own and go to the bathroom. They're not holding it through the night. It's just they're going to the bathroom. And some people need to go twice a night. So did it go away when they're adults? The nocturnal enuresis went away. I mean, they're still peeing in the middle of the night. They're just waking up. So again, getting them to set their alarm, getting them used to waking up is the key. There's no training methods like you see with the typical patients.
I also see a comment from someone who is needing credit for the course, so you'll need to complete the pre-test, the post-test, and the evaluation for that.
I think we are right at 2 o'clock, and I'm not seeing any more questions. So thank you so much, Dr. Fixler, for presenting today, and thank you all for joining us.
You're welcome. Thank you.